Well, good afternoon, everyone. It's my pleasure to moderate this speaker series. This is the last speaker series of our calendar year before the holidays, and it's my great pleasure to welcome all of you to our talk entitled AI in Primary Care by Stephanie Garies, who is a postdoctoral fellow at the University at Unity Health in Toronto with Dr. Andrew Pinto. So I'd like to, welcome all of you to this event. Certainly with T-CAIREM, we have had the great pleasure to host many such series to really inspire trainees and faculty across our community within the University of Toronto, as well as across the country in AI applied to healthcare. And so before we get into the program today, I'd like to start off with a U of T land acknowledgement. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. T-CAIREM, or the Temerty Centre for AI Research and Education in Medicine at the University of Toronto, has been made possible by the generous donation of the Temerty family. T-CAIREM is an interdepartmental center that serves as a focal point for collaboration among healthcare providers, trainees, researchers, computer scientists, engineers, and industry. Our goal is to transform health through AI. So I would request that all of you please use the Q&A function in Zoom to submit your questions for Dr. Garies. She will address them during the discussion portion of this webinar. Additionally, one final note is that by attending this event, you're consenting to being recorded for non-commercial use for T-CAIREM. So I'll move on to Dr. Stephanie Garies' biography. It's my pleasure to welcome you to present today's seminar series. So Dr. Garies is a CIHR Health System Impact Postdoctoral Fellow embedded in the St. Michael's Hospital Family Health Team, supervised by Dr. Andrew Pinto and Dr. Karen Weyman. Her postdoctoral work aims to explore the use of artificial intelligence methods to derive information about patients' social determinants of health from their electronic medical record. She will be working with the FHT to co-design a way to present this information in a meaningful and actionable way. Thank you so much, Dr. Garies, for taking the time to join us today, and we look forward to your presentation.
Okay, thank you so much. I'm excited to be here and share a little bit about AI in primary care. Obviously, it's quite a broad topic, so this is only going to scratch the surface, I think. Okay, so I also want to provide a bit of a land acknowledgement. So over the last 2 years, my work as a postdoctoral fellow with the St. Michael's Family Health Team has taken place on the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, Chippewa, the Haudenosaunee, and the Huron-Wendat peoples. And I spent some time in Toronto, really enjoyed it there. At the moment, I'm physically located in Calgary, Alberta, and finishing up my postdoctoral fellowship remotely from Calgary, as well as continuing a little bit of work with the Department of Family Medicine at the University of Calgary. So I'm, of course, very grateful to be able to work and live on the traditional territories of the people of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Goodstoney First Nations. And the City of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. And of course, as we think about working towards truth and reconciliation, I just wanted to provide some resources that have been helpful for me. Of course, we all are interested in data or work in data-intensive environment. So the fundamentals of OCAP course has been really valuable in terms of learning about First Nations principles towards ownership, control, access, and possession of their data and data collection processes. So if you haven't taken that course, I'd highly recommend it. And of course, there's lots of different webinars. So the Poplar Network in Ontario has some really great webinars posted on their website that includes one around Indigenous data sovereignty. And then just recently, the Canadian Primary Care Research Network hosted a webinar to describe the Indigenous Health Data Governance Toolkit, and you can view that online as well. And I can make these slides available afterwards too. In terms of disclosures, I don't have any conflicts of interest to declare. My postdoctoral salary is funded through CIHR Health System Impact Fellowship Program and Unity Health Toronto. I've received some awards from Unity Health, some honoraria from the Alberta SPORE and the Michener Institute, and I've been a co-investigator on a variety of different research grants. I don't get paid out of these, but they do help to support some of the research projects that I'm involved with. Now, for the formal learning objectives, really just to have a very basic understanding about primary care data, review some opportunities for and examples of AI in primary care, and then we'll just talk about a few high-level considerations for implementing AI tools in this space. So for today, we'll go through, what is it about primary care that's, important for AI. We'll talk about data, applications, and some implementation. So I couldn't do an AI presentation without using AI to help build my presentation. So I just discovered that Canva actually has some generative AI embedded in their platform. So when I typed in primary healthcare, this was the graphic that it chose to create. And it's getting there. So it's sort of showing different patients and care providers providing care in the community. It looks like at some offices or places of work. And so I think that's what's really important about the primary care system is that it's really foundational to our overall healthcare system. This is where the vast majority of patients come into contact with the healthcare system. So in primary care, the goal is to deliver comprehensive, relationship-based preventative care all throughout the lifespan. So primary care providers are doing everything from well baby visits to seeing their, most elderly and frail patients with medical complexities or a lot of comorbidities, and then of course everything in between. So it's a really, really broad space to work in. In primary care in Canada, there is actually a really high uptake of electronic medical records, which is great because this also represents a really important and accessible source of data that we can use for AI applications. And of course, we can, seek to use digital health tools or AI in a variety of different ways to enhance patient care, to help address health inequities, to improve clinical workflow, and hopefully reduce the administrative burden. Now, primary care is not doing well at the moment. I'm sure you've seen these headlines or others that are quite similar. But it's been a really tough time in primary care. So primary care providers are facing extreme burnout. There's a really high administrative burden. I heard recently that family physicians are expected to do something like 10 to 20 hours of administrative work every week, in addition to their full-time clinical work. So it's no surprise that we're seeing shortages of family physicians and other primary care providers. They're really working with stretched resources, managing an aging population with growing medical complexities. And of course, as the COVID pandemic highlighted, we have real inequities in patients' access to healthcare and patient outcomes as well. And people just aren't interested in family medicine training. So there's been a lot of declining interest and medical residency spots that are just unfilled in family medicine. But this is where I think AI can have a real big impact in addressing some of these facets of the crisis. So this is just showing you where most of the AI research is happening in different medical specialties. And you can see that there's a lot of studies being generated in oncology, pathology, radiology, and surgery. And over here, we have primary care. So I do think that this is not a bad thing. I think it's actually a really exciting opportunity. There's a lot to be discovered, a lot of different applications that can make really big impacts in primary care. Now, luckily, we don't have to think about what would be helpful in terms of AI in primary care, because some really smart colleagues of mine have already figured this out. This is work led by Dr. Jacqueline Cooper. They held some deliberative dialogues with patients, primary care providers, and leaders across Ontario to try to come up with a list of priorities for AI in primary care. And this is a ranked list. So at the top, the need is for AI to help with preventative care and risk profiling. In second place, AI to help with patient self-management of their conditions. The third is really interesting, AI to help with the management and synthesis of information. There's a lot of data in electronic medical records or EMR systems, but AI could be really useful even just for that simple task of summarizing information or collating information to be able to help providers with decision making. In fourth place, improved communication between primary care and AI stakeholders. This is, of course, really important when you're designing any sort of AI project or tool. You really do need to engage with the primary care clinicians sort of as the end users of this right from the very beginning. So more communication there. Data sharing and interoperability, obviously a really big topic that affects not just primary care, but lots of different other care settings in our healthcare system. And then tied for sixth place, clinical decision support and administrative staff support. And the last two just around task support and mental health care capacity and support. And so you can read a bit more about this. I just left the QR code there. And I'll just talk very briefly about data. Obviously, without data, AI is just not possible. So what do we have in primary care? Well, as I mentioned, most family physicians are using an EMR system in their practice. So EMRs sort of came about as a digital replacement for paper charts. And unfortunately, the earlier versions of EMRs weren't designed super well. They were just mimicking how you would fill out a paper chart. And that kind of leads to a lot of this administrative burnout that we've been hearing about and talking about. But there is a lot of really rich longitudinal data in primary care EMR databases. It's relatively accessible, and I'll talk about a few sources in just a minute. But if you can imagine people coming in to see their family physician, oftentimes you might have 5, 10, 15 years worth of data and all sorts of things related to current and historical diagnoses, physical measurements like heights, weights, blood pressures, referrals, prescriptions, allergies, immunizations, sometimes a bit of social data. So it's a really, really rich source. And you can access primary care EMR data for research. So the Canadian Primary Care Sentinel Surveillance Network, or CPCSSN, is a pan-Canadian collaboration of primary care practice-based research networks that collect de-identified EMR data from family physicians and nurse practitioners across the country. The national database has roughly 2 million patients. It might be just slightly under. But again, really rich data source that is available for things like research, public health surveillance, quality improvement. In Ontario, Poplar is sort of a provincial network of 7 practice-based research networks. Poplar does feed into CPCSSN as well. So they hold de-identified EMR data for about 1.5 million patients in Ontario. Their data holdings are a little bit more broad, so they will eventually include things like progress notes. And Poplar also can support multi-jurisdictional clinical research in Ontario. I think they're still just sort of working out their internal processes, but that's going to be an extremely valuable resource for both data and clinical research in Ontario. Okay, now I'll go through a few different projects that I've been involved with, and I'll give you a sense of how AI can be applied for use in primary care. So the first is related to my postdoctoral work. This was funded by the CIHR Health System Impact Fellowship. And it was working with the family health team at St. Mike's. They've been distributing a patient survey for about the last 10 years that asks about different aspects of social determinants of health. They only have completed survey responses for about a third of patients. So the question that came from the team to me was, is there a way to use EMR data to see if we can derive social determinants for the other 2/3 to help with things like resource allocation, program planning, practice, kind of practice activities. And so that was the first objective. The next 2 objectives were qualitative work, just to understand if we could build this AI tool that could derive social data from the EMR, what do primary care clinicians think about this? And so we interviewed family physicians and primary care leaders across Ontario to understand their perspectives, if they think it's a good idea, bad idea, what are some of their concerns. And then the last objective was to co-design this tool with the family health team, just to understand how it might be integrated into their workflow, what additional resources might be useful, and what they would like to see out of it. And so we worked with data from about 17,000 patients. Those were patients who had had a visit with the family health team and who also had completed the health equity questionnaire, this online survey asking about social determinants of health. And that acted as the reference set from which we built some supervised machine learning models and also tested a rule-based approach. So could we derive some of this just using some simple key term searches? So the findings are still, we're still finalizing some of them, but we focus specifically on 5 determinants. And overall, the accuracy was sort of all over the place. machine learning worked a little bit better than the rule-based approach for immigrant status. For housing instability, the rule-based approach was actually quite accurate compared to the machine learning. But again, we're testing out a few other approaches for the progress notes to see if we can enhance that. Income insecurity, the rule-based approach was okay at about close to 70%, and then the machine learning was just over 70% as well. A couple of the challenges with this type of work is around, the use of progress notes in the machine learning model. Progress notes are sort of the narrative free text that is in the EMR that clinicians sort of document what happened during that visit. There tends to be a lot of noise, and these determinants are not always found in the chart at all. There was also issues with things like class imbalances, especially when we're looking at gender, sexual orientation, and housing instability. So this work is still in progress. We haven't quite published anything, but I'd be happy to share that when we do. So another use of AI is really for some data science methodology. So this was a paper we published just a few months ago. So we have this pan-Canadian EMR database, but a lot of the medication information is found as free text. And so if you wanted to, for example, look at patterns of antibiotic prescribing, it would be really challenging to find every single antibiotic name in order to include that in your analysis. So what we did is used a semi-supervised machine learning approach using the Health Canada drug product database as our reference set. And we tried to codify the medication text into an ATC code, which is the anatomical therapeutic classification system that's maintained by the World Health Organization. And in ATC codes, you can actually group different classes of medication together, depending on how many digits you use. So this is a really useful coding system. And we developed this ML tool that works actually pretty well. We had quite a high accuracy when we reviewed the antibiotic medications. So now instead of trying to look at every single name or misspelling of the prescription medications, you can just identify them using an ATC code. So another area is around public health surveillance. And this is work being led by Dr. Andrew Pinto. We're working with the McMaster Family Health Team to try to develop an automated ML-based tool to identify early outbreaks of respiratory illness. And so how this would work is the tool would run in the background of the electronic medical record, and it would send aggregate information to, say, Public Health Ontario. And hopefully we can help to identify maybe early outbreaks of novel respiratory infections kind of before, kind of in an early sense, so that we can deploy resources appropriately based on region. And then lastly, addressing the family physician administrative burden. So this is not AI. These are actually real people and real pictures. But this work is being led by doctors Frank Rudzik, Noah Crampton, and Andrew Pinto. I'm really happy to be involved with this because I think it's such an interesting project, and I really think it has the potential to transform some of this administrative burden that is really contributing to burnout among family physicians. This project also won a family medicine Temerty innovation grant recently. And the work will first develop a time motion study. So we'll be observing family physicians in their workflow to understand how they use and interact with the EMR system, and to be able to identify a few almost low-hanging fruits that we could automate. So for example, when they're typing in the notes, if there are certain key terms that would create an automatic prescription for that patient, or an automatic referral. So the referral template fills out automatically, the physician quickly reviews it and then sends it. Then we hope to pilot and evaluate this tool in several family medicine clinics. Okay, and now I'll just go through some high-level considerations for implementing AI in primary care. So this is not a surprise to anyone, but AI and data science really are team sports. I think it's so important that we engage early on with patients, clinicians, and communities, and co-design the AI throughout the entire process. The questions really need to come from practice. So it needs to be led by primary care clinicians and patients who articulate, this is the problem we're struggling with. Can we help to co-develop a solution together? And then obviously everyone's heard a lot about, the biases in AI. So I think, especially in a healthcare context, that we really need to think so carefully about bias and fairness. And even the consequences of, false positives and false negatives. So what happens if a patient is not accurately categorized? What does that mean in terms of, resource allocation or diagnosis or treatment of their condition? There's, the old tech saying, move fast and break things. I would argue that, we could be moving a little bit quicker, but I don't think that this is an appropriate slogan for AI in healthcare, because there are so many risks to patient safety, and we want to ensure equity and reduce bias as much as possible. And so this little QR code that I've put in here does a really good job at describing lots of different barriers and strategies in the implementation of AI into Canadian healthcare settings. And then here's just a few other resources that I've, turned to at times. So Canada Health Infoway has a really helpful toolkit for AI implementation in healthcare. It's largely targeted at healthcare organizations who are thinking about bringing in an AI tool. It goes through, it has nicely packaged modules that go through some risks, regulation of AI, some opportunities, change management, which is a major piece when you're thinking about implementation, and some governance. And then there's a couple other papers published in CMAJ. I'm sure these are familiar to most of you, but implementing machine learning in medicine and the evaluation of machine learning solutions in medicine, both, are not specific to primary care, but I think lay out some really key design stages and evaluation steps that are really helpful when you're working in this space and you're about to implement or thinking about an evaluation plan. And then lastly, the Upstream Lab has a lot of different resources. We have a series posted on the website around AI in family medicine, a webinar series that was hosted by the College of Family Physicians of Canada, as well as just some more general AI in healthcare resources. So that's it. I think I finished a little early, but that's great. Now we have a bit more time for questions. So I'll stop sharing.
Okay. Well, thank you so much, Stephanie. That was really a wonderful talk on, very practical applications of AI in family medicine. And, certainly, as you say, there's a lot of opportunity to help in terms of streamlining processes in the family medicine setting and helping, family physicians really then focus on, interacting with patients and, ultimately reducing all of that sort of paperwork and administrative work and really just focusing on really that interaction and ensuring that they can do the best for their patients. So let me take a look at the Q&A here. There is a comment from Paul Dolinar here. So I think it's just a general comment. Speaking to patients, providing direct care is a real pleasure, but dealing with the EMR and keyboard, on the other hand, isn't.
Yeah, I totally agree. And I mean, I don't think family physicians get into this business because they enjoy sitting in front of a computer all day and all night long. I think there's so much opportunity to create EMR systems that are easier to use and are more conducive to family medicine workflow. And ultimately, I don't think that family physicians should have to, do things like billing. I think that we have the technology to be able to auto code in the back end of the EMR.
Mhm.
But it's, it can be quite complicated just when you're dealing with EMR vendors and sort of archaic coding systems as well.
And so along those lines, I see a question from Mary Aglipe. Along those lines, could you speak to the major barriers of uptake of AI in primary care?
Yeah, I mean, I think there's a lot of different barriers. I think there's, maybe a culture that is a little bit more hesitant to, you know, do things differently, try out new innovations. I would also say the EMR system itself tends to be quite a big barrier. It can be difficult to even just get data out of the EMR. You need that to be able to build AI tools or to even test out digital health technologies. And then to implement those tools back into the EMR can, depending on the vendor, can be impossible or cost an absurd amount of money. And some EMRs were just not designed for AI technologies. They still are quite old in their architecture. There are some more newer systems coming onto the market, but yeah, I think that one's quite a challenge.
Yeah, I think, one question that I'd like to discuss maybe a bit later once we've had a chance to go through some of the questions here is, say, your thoughts on, different primary care settings. So say in Canada with the public healthcare setting, as opposed to say in the US where, say the use of certain EMRs is quite widespread, and what that means for, increased interface between increased or differences in the interface between say primary care and say specialists to whom patients are referred. So I work as a transplant hepatologist at the Toronto General Hospital, and we've had Epic in use for over a year now, and I understand that there are other institutions now, beyond those that have already uptaken Epic, that are now also looking into purchasing access to Epic. And so, what are your thoughts in terms of what that means for AI tool deployment and primary care? What have been the experiences of, say, people in the US versus public health care?
Hmm. Yeah, I mean, I think in terms of the US, they have an advantage in that many of their systems are sort of closed. So it's a closed health management organization where they can all be on the same EMR system. And they have money to be able to pour into these types of technologies and testing out different AI tools.
Mm-hmm.
Whereas in Canada, primary care still sits very much outside of the healthcare system. And so primary care physicians are basically independent business owners. And so they, bill the government based on visits that they conduct, and basically have to manage their own practice and resources.
Mm-hmm.
Um, which also means that they get to choose which EMR system they have in their practice. And
Mm-hmm.
up until fairly recently, well, and still now, these EMR systems don't talk to each other. So even if you see a walk-in clinic and then you go back to your family physician, they could still be on the same EMR, but they don't talk to each other.
Mm-hmm.
So I think interoperability is a huge concern,
Mm-hmm.
not only in connecting primary care with the rest of the healthcare system, but even just between different primary care providers.
Right.
And again, we need, I think, governments to step up and to be able to properly support family physicians in terms of getting compensated for the work that they do and the technologies that they have access to.
Mm-hmm. Mm-hmm. So there's the next question is from J.K. Cooper. For the automation work, in addition to expected positive benefits on family physician workload, what types of impacts do you think there will be on EMR data in general for communication with other providers and care teams, patients, caregivers, etc.?
Thanks. That's a great question. I mean, I hope that it will produce data that's a bit more consistent. So one of the challenges that we face is that there is a lot of free text in the EMR, which I think is preferred by family physicians when they are documenting. They're not constrained to, a certain field or drop down. It just sort of allows them to be able to say what they want and document that into the EMR. But unfortunately, when you're using that data for secondary purposes like QI or research or anything, it becomes really, really challenging to work with. In some of my work that I did in Alberta a number of years ago, I think we found that there was over 60 different ways of saying diabetes in primary care EMR data, just in one province. So there's a lot of cleaning and processing that has to go on if you wish to use those data for purposes other than direct patient care. But so I think, with the automation work, I hope that it will produce more consistent, maybe even coded data. And then the second, in communication with other providers and care teams. Yeah, I mean, again, the hope is that this will automate tasks in the EMR so that the physicians have more time to spend with patients and caregivers and not sitting in front of the computer trying to get all these forms filled out, because otherwise they're doing them after hours. They'll get home, continue on with the documentation. So I do hope that this will provide just a better interface with patients.
Good. I see another question here from Abbas Zavar. And so I would welcome everyone to input any questions you have into the Q&A chat here. Abbas asks here, in Ontario MD, we are actively working on AI in primary care by doing a comprehensive environmental scan to identify any AI-enabled solutions that might be used by primary care physicians. Also conducting several pilot studies to evaluate AI tools and their efficacy on physician burnout, and more are coming. Okay, so
That's
this
amazing.
appears to be a comment rather than a question, but anyways, maybe you can tell us your thoughts on this.
Yeah, no, I think that's really great to hear. And I was at the T-CAIREM conference in October, the AI for Health conference, when one of the speakers did mention that we don't currently have any registry of, AI tools that are available for use in clinical settings. And I think that's a really great resource to have, is, to share with the primary care community. These are potential technology solutions that you could use in your practice, and just have sort of a list. I would even go further than that and just have sort of a checklist of maybe which ones have been validated, which ones report on, accuracy metrics, or, have dug into issues around bias and fairness as well. But yeah, that's really exciting to hear, and hopefully we see that published soon.
That's great. Okay, thank you, Abbas. Mike Lim asks, how do you envision AI helping with a patient virtual visit with their family physician?
Yeah, I mean, I think virtual care is a great option to have as a modality for patients connecting with their family physician. I mean, you could, even like how we use in Zoom, we have sort of AI that can transcribe conversations really quickly. And so maybe that's something that could be embedded into the EMR after that virtual visit. Sort of key action items, or, that SOAP, the subjective objective assessment and plan, could be embedded directly into the EMR. I worry a little bit about sort of the private companies who are operating in the virtual care space, just because, it might seem like a solution for addressing the fact that not everyone has a family physician, and it's really hard to get one these days. But, you know, it does tend to lead to more costs to the healthcare system. And we know that continuity of care with a family physician who knows you and sees you regularly is better for patient outcomes and health system cost in general. So that's the only type of virtual visits that I'm a little bit concerned about, but I do think it's a great option for family physicians to have for their patients.
Okay, great. To what extent do you think the current privacy environment legislation enables or discourages AI adoption in primary care?
Yeah, I mean, that's another great question. And I don't know if I have a succinct answer to that. I think we need more legislation um, around AI and regulating AI, especially in the healthcare space, because I think there's very little, if any. I know that there is some being developed right now, but in the US, I think it's the FDA actually does evaluate AI-based tools and technologies for use in a clinical setting. So they do have that mechanism there. We don't really have anything comprehensive and robust like that yet, but I think it's super important. I mean, the other piece to that is health information legislation with regards to data. Obviously, data is really a critical piece in any sort of development of AI. So you know, there are some regulations and legislation around the use of de-identified data, but I think that could be strengthened as well.
Yeah, I completely agree. I mean, I think in the US they've been quite active and proactive in that regard. And there are a number of FDA approved applications in radiology and pathology. Over 100 of them, I understand. So certainly with imaging data, there's been a lot of advances when it comes to, say, clinical notes and or clinical and laboratory data. That's been somewhat slower. And I think we do tend to deploy tools if we feel that they're safe enough and deploy them prospectively, from a QI perspective, if we think that they're solid enough. But certainly there's a lot of work to be done to have proper mechanisms in Canada for regulation of AI tools in healthcare.
Yeah,
Um,
I totally agree. I'll also just add, we do place an unfair burden on the physician in terms of deciding if they think the AI is robust enough or safe enough to adopt into practice. But I would like to see, more clear regulations around that, and maybe just ways to better support physicians when they're making decisions around AI and digital health technologies.
mhm. Okay. Let's see. So, Paul Dolinar asks, any way my little CHC might assist with our messy client data in your efforts? What is the CHC?
I'm going to get community
Familiar
health
with that
care.
acronym, actually.
Community health.
Community health care.
Yeah, feel free to email me and we can chat a bit more.
Okay, great. Then Mike Lim asks, do you foresee AI being able to offer some decision support to the family physician, perhaps by analyzing in real time the patient history in the EMR and the current condition vitals presented during the visit?
Yeah, I mean, I think anything's possible. I mean, currently the EMR data are quite messy, and because you have so much of it in a longitudinal fashion, it can be quite difficult to sort of utilize all those data in some sort of predictive fashion. But certainly there's no reason, and there are others working on clinical decision supports in primary care.
Mm-hmm.
I will say though, I think family physicians really enjoy that part of their work. They enjoy chatting with patients and making diagnoses or sort of helping to address some of these issues. I think where AI could have such an extremely useful impact is things like helping with documentation or synthesizing information in the EMR or, automating prescriptions or referrals, just taking some of that administrative burden away.
Mm-hmm.
Um, I think that's probably a priority. Not to say that clinical decision support isn't important, but I think that's one piece that family doctors are quite good at and they enjoy.
Yeah. Yeah. No, I completely agree, especially with generative AI tools that are that have been developed and are in development. I think there's a lot of opportunity there to really streamline workflow with respect to administrative burden, paperwork and administrative burden. Okay, so I think we'll take one final question here from Yvonne Lung. The AI system needs proper program evaluations before physicians can adopt it. The question is, who is paying for the proper evaluation? Can an organization such as Ontario help?
I mean, that's a really great question. I mean, I work in a research environment, so in an academic setting. So, we would build that into our grant application. So we would build something and then, have a robust evaluation as well. I do think there needs to be really clear regulations and guidelines around how these AI tools or systems should be evaluated before they're put out on the market. And what is the accuracy? Does it perform as well between different subgroups of patients? I think all that needs to be sort of presented and available in the public sphere when you are putting these AI tools out into market. But again, I'm coming at this from a very different perspective from sort of research, and we like to do these types of things and can usually get grant money to help support it. But yeah, I do think it's maybe a responsibility of provincial and federal governments.
Great. So I think with that, we will conclude today's session. So thank you so much, Stephanie, for this wonderful talk. And thanks to everyone for attending and participating with your questions, those excellent questions at the end. Please keep up to date by following us on Twitter and subscribing to our mailing list. If you haven't yet joined T-CAIREM, consider this your invitation. We're now one of the biggest AI and medicine networks in the world, and we want you to be a part of it. All the details are on our website at tcairem.utoronto.ca. Quick mention, this event is CPD accredited. To obtain your CPD credit, please complete the evaluation form that we will email to all attendees following this event. And don't forget to provide your name and email address on the evaluation form. So thank you so much, everyone, for attending. And actually, here is the link for the CPD certificate. So there's a SurveyMonkey link. So please fill this out in order to obtain your credits. Thanks so much, everyone, and hope to see you next time. Happy holidays.
Thank you. Bye.
Bye-bye.